Hello everyone. Hello everyone, and welcome to this audio podcast. This audio podcast is part of the syndicate. This audio podcast is part of a Bostic syndicate. This audio podcast is part of a Storm and Saga analysis. This audio podcast is part of a as part of the series The Squallish, and this audio podcast is part of a Storm and Bostics production. Through this audio podcast today looking at they'll be looking at sort of primary care or the primary care health sector in regards to in line to chronic kidney disease or CKD. So in through this audio podcast, looking at establishing cause and precluding or preventing CKD. So CKD occurs at various ages and through various and can affect the various populations. And depending on the form of CKD, there can be incidences and prevalences across different ethnicities and populations. So some of the common causes of CKD include nephropathy, and nephropathy being in around where the functional components of the kidneys have a sort of a sense of a sense of inflammation and can cause sort of pathophysiology, renal pathophysiology to be sort of affected. And then additionally, sort of a cause of CKD is in around the anomalies in around arterial blood pressure and renovascular sort of symptomologies. Excuse me. Then a additionally, where there can be a another cause is glomerulonephritis. So inflammation of glomeruli of the actual filtering components of in around the kidneys. And then there's interstitial nephritis due to reflux nephropathy. And then there's PKD or polycystic kidney disease. Polycystic kidney disease is in two forms. There is autosomal polycystic kidney disease, autosomal dominant polycystic kidney disease, and autosomal recessive polycystic kidney disease. Um, and then there is another cause. Another cause can be obstructive uropathy. Obstructive uropathy is sort of more sort of more sort of sort of more sort of implicated in sort of pediatrics and young populations. Although in adult populations, obstructive uropathy can also occur. So in around the CKD stages, chronic kidney disease stages. So stages one to two in around CKD, there's generally in regards to primary in around the primary healthcare sector. Literature informs that there is annual monitoring of such recipients in around CKD stages 1 and 2. CKD stages 1 and 2, from additionally listeners and viewers, is that CKD stages 1 and 2 can actually in as part of laboratory investigations, different laboratories in regards to the analysis of CKD stages 1 and 2. CKD stages 1 and 2 generally can differ. And at the same time, stages 1 and 2, CKD stages 1 and 2 are not sort of sort of implicated in as part of the sort of severe spectrum of CKD. Then there's CKD stage 3, and CKD stage 3 is in amongst literature is sort of divided into two sort of divided into two bases. So CKD stage 3, there is a sort of a stable basis of CKD stage 3, which in literature is where much like that of CKD stage 1 and 2, the sort of follow-up is for recipients is to monitor annually. And then in around progressive CKD stage 3, where the CKD and estimated glomerular filtration rate is more than where the estimated glomerular filtration rate (EGFR) falls more than 2 mL per min per 1.73 meters squared over 6 months or more. And the literature has informed that the monitoring is around on a 6 monthly duration. And then in around CKD stages 4 and 5, the monitoring is in amongst the literature around 3 on a 3 monthly duration. So in around now, looking at cause and prevention. So establishing the cause, which usually requires imaging and radiological investigations, and may require biopsy procedures, is and can be important, because in some cases treating the primary disease prevents or precludes renal damage. Additionally, sort of control of arterial blood pressure and the reduction of additional sort of primary symptomologies can preclude or prevent deterioration in amongst renal function. And then additionally, laboratory investigations can be implemented to determine ESRD or end-stage renal disease. Additionally, also in regard to establishing the cause and precluding or preventing of CKD, pharmacotherapeutics that counteract the action of and in around a path, a sort of an interlink between what is referred to the afferent and efferent arterioles of the kidneys. For example, it is where the interlink referred to as a pathway of what is referred to as in literature as the angiotensin 2, the sort of angiotensin 2, where angiotensin 2 pharmacotherapeutics that can counteract in around angiotensin 2, and also slow the rate of CKD progression in both in around different symptomologies aligned to renal sort of anomalies, and aligned to CKD, or chronic kidney disease. In about quarter of recipients receiving RRT or a form of RRT or renal replacement therapy, the cause of the underlying renal disease is the cause of underlying renal disease or etiology is and tends to be documented and sort of coded according to specific sort of specific guidelines. That being said, historically or retrospectively, clinicians have not been able to, for example, code a sort of particular conditions in a sort of in and as part of a sort of a mainstream or streamlined sort of basis, owing to excuse me, owing to the differences in as part of different healthcare records and line to epidemiological data. However, at the same time, data have allowed tracking and documentation in as part of some CKD complications. So treatment of anemia or low hemoglobin with recombinant with what have been as a pharmacotherapeutic are referred to as recombinant human erythropoietin can avoid the requirement of and for blood transfusions and improves quality and can improve and can help bring the hemoglobin to a parameter of and in as part of normal physiology. The management of renal anemia in sort of generally is coordinated is generally coordinated by specialists, either specialist nurses or clinicians, which sort of specialist clinicians and or specialist nurses in around the nursing profession, and between sort of primary and secondary healthcare sectors in as part of assessment and prescribing and monitoring of in and around the pharmacotherapeutic. Treatment of iron deficiency is also required to maximize the efficacy, if you like, of and in around the mechanistics of where erythropoietin is used or utilized, such that the pharmacotherapeutic can bring a sense of homeostasis, referred to as erythropoiesis. And intravenous iron in amongst literature has been documented and evidence that can and has been utilized in specific cases and again as documented in amongst the literature. Additionally, there is a symptomology in amongst the literature that's referred to as mineral bone disease. So the management of mineral bone disease, or MBD, in chronic kidney disease is and has been complex and rapidly advancing, and where the symptomology has also been rapidly advancing as new pharmacotherapeutics to control, for example, calcium, phosphate, and parathyroid levels are and have been clinically trialed and investigated and or experimented. Calcium, phosphate, and intact plasma parathyroid should be measured in recipients with CKD and where the G and aligned to the GFR, glomerular filtration rate, and especially if the glomerular filtration rate or estimated glomerular filtration rate is less than 60 ml per min per 1.73 meters squared, according to sort of guidelines, and in amongst some some literature. In regard to now, just a quick look at renal replacement therapy preparation, or RRT preparation, in regards to as part of between sort of primary care and secondary care. So late referrals, and there has been some literature to inform that late referrals, for example, by general practitioners or family physicians, for example, family physicians, where late referral has been evidenced as sort of propagating sort of issues in amongst secondary care. So late referral is defined as referral of recipients with progressive renal function, progressive renal function from primary to secondary care less than three months before the need to begin a form of RRT. And about a third of recipients are referred to a specialist clinician known as a nephrologist at a late stage of renal disease, and this is associated with poorer state of at the start of renal replacement therapy or kidney replacement therapy, and worse outcomes, and where there's a poorer sort of state of the start or the initiation of RRT or KRT, there is then or can occur worse outcome and higher healthcare sort of costs and implications. All recipients with a progressive increase in serum creatinine level, for example, would need referral to a specialist clinician and sort of prepped for a form of RRT or KRT. Additionally, there is identifying and treating reversible causes of renal ESKD or ESRD is and has been is important or pivotal. Secondly, slowing the progressive decline in renal function is important, and managing the complications associated with CKD additionally are pivotal. The entry into RRT or KRT programs for most recipients who might see a sense of advantage requires involvement of MDTs, multidisciplinary teams between healthcare sectors. CKD must also be identified in amongst primary care at early stage, so the appropriate treatments or pharmacotherapeutics can be initiated, and the need for specialist referral is assessed. And then evidence also suggests that recipients with CKD can go underdiagnosed. The majority of recipients in amongst the literature with CKD do not undergo routine monitoring, have not undergone routine monitoring of renal function, although literature differs in regard to renal kidney function and or related parameters, so laboratory parameters, to enable appropriate management of complications or symptomologies. Implementation of guidelines relating to the identification, management, and referral still have required a considerable change in the current practice or practices and additional resources in amongst primary care. So in sort of closing, closing in on this audio podcast, the main elements or aspects to monitor in amongst primary care. In amongst primary care is in around ABP, FBC being a full blood count, and where the full blood count sort of factors in hemoglobin, and amongst other red cell parameters, and then additionally monitoring sort of creatinine and utilizing sort of EGFR EGFR calculation, and then sodium and potassium, calcium and phosphate, and parathyroid or parathyroid gland, and then urinalysis, and then a sort of pharmacotherapeutics or polypharmacy, including any over-the-counter sort of medications or medicines that healthcare service users may use. So that draws this audio podcast to a close. This audio podcast as part of the syndicate. This audio podcast is part of a Bostic syndicate. This audio podcast as part of a Storm and Saga analysis. This audio podcast is part of the Squallish Series or edition, and this audio podcast as part of a Storm Lobostics production.